Today we are going to listen to the presentation by Dr. James Edward, who is our Joint Chief Chiropractic and Compliance Officer. He's going to be presenting this presentation based off of a video from the Association of the Chiropractic Colleges presented by Jerry Klum. So for those of you who have not met Dr. Edwards before, he is, as I mentioned, our Chief Chiropractic and Compliance Officer. He has had over 38 years of clinical practice and has spent 8 years on the Kansas Board of Healing. He also has 15 years in the state association leadership and 12 years as ACA leadership, including chairman of the Board of Governors. And most importantly, he is an expert witness, or has been an expert witness, in over 100 chiropractic malpractice cases, some of which have been involved with strokes. So I would like at this time to turn the call over to Dr. Edwards, and he's going to take us through the presentation today. Dr. Edwards, are you there?
Yes, I am. Can you hear me?
I can.
Very good. Wonderful. Welcome, everyone. I'm in hope of giving you some important information that every DC should know, and from a risk management standpoint. So, Shannon, I do not. For some reason, it's dropped me off of the website, but that's all. Oh, well, maybe I've got it here. Okay, now. Okay, so the next slide, please. Very good. This is based on a 2-hour presentation, or almost 2 hours, by Dr. Jerry Klum with the association, like Shannon mentioned, and with the Association of Chiropractic Colleges. But this is sort of like Dragnet, Jack Webb. I'm going to, where you used to say just the facts. Well, I'm going to give you just the facts, but the facts that I'm going to give will be enough for you to be knowledgeable about this subject. We're going to cover anatomy review. We're going to cover, very briefly, we're going to cover history of blood vessels review, very briefly. And then we're going to review a basic pathology mechanism. Next slide. Arterial circulation. The origin of the vertebral we're going to talk about very briefly. The origin of the vertebral arteries, the course of those arteries, and their distal distribution from the vertebral arteries. Next slide. The left and right vertebral arteries arise from the subclavian artery. Next slide. From the subclavian artery, they both come up on the right and the left, and they transverse through the foramina from either C5 or C6 to C2, and then through the C1 transverse processes. So you can see that when you're making cervical adjustments, these arteries are involved in that process and why they're so important. Next slide. Next slide, please. Next slide, please.
We are on the histology of blood vessels review. Is that not the slide you want?
No, that's okay. Can you go back one then? So, maybe I missed it. Can you go back just one?
So arterial circulation?
Yes, please.
Okay.
Okay, and we've skipped a couple here. Go back one more, please.
Okay, now we're back on the arterial circulation with the course of the vertebral artery.
Yes, and the vertebral arteries, maybe I missed it, they come up and they either enter the cervical spine at either C5 or 6, and then they go to C2, and then they go through the C1 transverse processes. Next slide. Once they get distally, they continue up the spine and they unite to form the basilar artery. But prior to the junction of the right and left vertebral arteries forming that artery, they form the posterior inferior cerebellar artery, pica as it's called, is given off. Next slide. So anyway, that's all the anatomy I'm going to do. That's where they come from. That's what they form. That's why they're so important. Now, as far as histology of the vessels, they're made up of three things. They're comparable in size and design to the renal arteries or some of the smaller coronary arteries. They exhibit the typical three-layer pattern from inside out, from enema, media, and adventitia. Next slide, please. Now, here's the origins, are the basics on a vertebral artery dissection. The literature indicates that vertebral artery dissection arises spontaneously from trivial movement, minor trauma, or even major trauma. And some of the things that have triggered vertebral artery dissections in the literature, including judo, yoga, ceiling painting, nose blowing, hypertension, oral contraceptive use, sexual activities, receiving anesthesia, use of resuscitation activities, receiving a shampoo over a sink, vomiting, sneezing, and chiropractic care. Next slide, please. According to Scott Haldeman, which was published in Spine, 43% of vertebral artery dissections are spontaneous in nature. In other words, they just happen. 31% were associated, and I've got that underlined, associated with cervical spine manipulation. That doesn't mean the manipulation caused it. It just means they were associated with the visit. 16% were from trivial trauma and 10% from major trauma. Next slide. For the incidence of a vertebral artery dissection, 1 in 1 million adjustments was the estimate by one expert. And again, we're dealing with associated. We're not saying that it's the cause, we're saying associated. 1 in 2 million adjustments by another researcher, and as high as 1 in almost 6 million cervical spine adjustments in another study. Next slide. So, Haldeman said, thus, given the current state of the literature, it is impossible to advise patients or physicians about how to avoid this problem when considering cervical manipulation or about specific sports or exercises that result in neck movement or trauma. So I hope you're getting the picture that there's not a lot of good science on this. Next slide. Current thinking holds that the majority of patients who develop frank symptoms of a vertebral artery dissection following chiropractic were in the process of this dissection when they presented for care. And your presenter believes that wholeheartedly. That's the problem. They're presenting with these symptoms, or they have these symptoms, but for whatever reason they're not picked up by the doctor of chiropractic, and why we're doing this presentation. Next slide. Now, when we were all in college, we were all taught that George's test or Decline's test and other tests, we were all taught these tests and told that, oh, well, this is, you know, what you need to do to make sure that that patient is not having a vascular problem. And the bottom line is, we were taught to do these tests, and the bottom line is, don't. Next slide. The reason is because George's test and others yield an unacceptable percentage of false positives and of false negatives. It tells you nothing reliable. So for the patient who truly does have a vertebral artery dissection in progress, those tests in and of themselves may be enough to make bad situation worse and very quickly. Next slide. Next slide.
I have it on March of 2004. All of the clinic directors of all of the U.S. chiropractic colleges and programs agreed to abandon the teaching.
It's not showing up on me. I'm still looking at pre-adjustment screening. Okay, there it is. It finally came up. I guess my internet's slow. In that regard, in March 2004, all the clinic directors of all the U.S. chiropractic colleges and programs agreed to abandon the teaching of and use of provocative testing of this nature. At that same meeting, the presidents and deans accepted the recommendation of the clinic directors. In other words, they're saying, we're not teaching it, it has no value, and don't do them. Next slide. The bottom line is this: there are no reliable or safe tests that will rule out a vertebral artery dissection in progress. And there are no tests that will identify a patient at risk. Your best evaluation tools, and this is what's essential and what we're getting ready to get into, is your ears and your eyes. Next slide. So anyway, what's a doctor to do? And if the great majority of vertebral artery dissections in progress and those patients present with musculoskeletal symptoms, like I said, what is a doctor to do? Next slide. Look, listen, ask, and think. Look, listen, ask, and think. It's time to stop when a patient presents with the signs and symptoms, and it's up to you as a doctor to be observant and trying to do the best possible thing for that patient. Next slide. And what you're looking at right now are these are the things that you look for. They're called the 5 Ds, the 1A, and the 3 Ns. First, let's just take them in order. Dizziness. Next, drop attacks. Next, diplopia, double vision. Next, dysarthria. Dysphagia, difficulty speaking, dysphagia, difficulty swallowing, ataxic, ataxia. For lack of a better term, losing your balance, falling up against the wall. And then there's the 3 N's: nausea, numbness, and nystagmus. So those are the things. When a patient presents with any of these signs or symptoms, it's time to stop. Do not adjust that patient thinking, hey, I'll make it better. Because if they're really having a vertebral artery dissection in progress, you won't, and you'll make it very bad very quickly. And we'll talk about that more in just a second. Next slide, please. To assist patients in informing the joint doctors, the joint intake form now has the following list of symptoms. You can find it under number 8. And what we're asking the patient in their intake form is these things. They're worded a little differently. They're not technical. They're more patient-oriented. Dizziness, numbness on one side of the face or body, difficulty swallowing, difficulty walking, difficulty speaking, fainting, lightheadedness, double vision, rapid eye movement, rather than using the word nystagmus, and neck or head pain like never before. So these things are now on the current intake forms. And if you'll take them out and look at them on number 8, they're there. And I would encourage you on every new patient you see, if regardless of how much or how little you review the intake forms, don't skip number 8, because it's built in for you to be able, for that patient, it's built in for the patient to be able to tell that doctor, I've got these symptoms. And when they have those symptoms, it's time to stop, look, and listen. Next slide. It's also important for your wellness coordinators to know those signs and symptoms, because when the patient walks into the office or the clinic, they're going to be the first ones in contact. And if they see any of those signs, they should drop everything and alert the doctor immediately so he or she can take action. Next slide. There's one characteristic that a patient can make, whether it's their first adjustment or their 100th adjustment of describing their symptoms. Next slide. And that statement is this: I have a pain in my neck and or head unlike anything I have ever had before. In other words, it's the worst headache or the worst neck pain I've ever had. That is the statement that is given over and over and over during a dissection in progress. So when a patient says, hey, this is the worst headache I've ever had, stop, look, and listen. This neck pain is the worst I've ever had. Stop, look, and listen. Next slide, please. Now, what you should do when a patient is presenting any of those symptoms that we previously discussed, what you want to do is say, tell me about this pain. Were you doing anything before? What are your symptoms? Paying very special attention to the signs and symptoms of a VAD in progress. Next slide. And of course, as I said previously, you stop cold in your track when you hear the phrase of the worst headache I've ever had. Next slide, please. When a patient shows signs of a possible VAD, either before or after an adjustment, Your management of the situation and your documentation are the most important issues in reducing morbidity and mortality, as well as limiting or reducing liability. Next slide. Your recognition of a post-adjustment symptomatic picture is critical. You cannot assume because a dissection in progress, a dissection is extremely rare, it won't or didn't happen. Keep your antenna up. Next slide. If the patient shows any of the 5 Ds, an AN, or any of the 3 Ns, pay attention immediately. If the symptoms are mild and they resolve, that's wonderful. If there's any doubt in your mind, you immediately call 911. I've done this 2 or 3 times in my years of practice, and all were negative and all were not a problem, but you just don't take that chance. Next slide. What symptoms should be monitored? Each situation will require a different response, but in general, you want to monitor the patient's vitals and stay with them. And here's the other thing. The availability of baseline vitals, like blood pressure, will cause this data to be more meaningful to you should this ever occur. And blood pressure is going to be a requirement during the intake process of a new patient. Next slide. The viewers can see that, and I've already discussed that to some extent, but if a patient is showing signs, do not, under any circumstances, readjust that patient at that time. If that patient's in distress or having problems, do not readjust that patient. Next slide. Stay with the patient. Watch for any symptoms so that you can advise emergency care of what's going on. Note the mental status, the degree of confusion, if any, and so forth. Last sentence. Do not readjust that patient at that time. Next slide. If they persist or so forth, and if you have any doubts whatsoever about the patient's condition, seek immediate emergency support. And once again, don't think you can fix it. Do not adjust the patient at that time. Next slide, please. I think I pretty well covered this one, but what will happen is if you do readjust, if you adjust that patient again, hoping that it'll help, it won't, because what it'll do is it's an introduction of another force that will serve as that could create an emboli and increase the likelihood of a vascular or ischemic event. Next slide. If the patient has experienced it and it has resulted in a thrombus being formed and emboli being thrown, it will likely result in, like I was talking about, an ischemic event. Emergency pharmaceutical intervention is the most effective in the first 90 minutes, moderately effective for 3 hours, and possibly effective for up to 6 hours. So time is of the essence. Next slide. Number one, the professional liability. Your failure to recognize what's going on and to write it off as normal or typical reaction to adjustment. You don't want to go there. Your failure to monitor and document the progress of the patient. Number 3, your failure to manage the situation properly and in a timely manner. Next slide. Readjusting the patient. I think I've covered that pretty well. 5, sending the patient home if in an unstable or fragile state. You don't let this patient get in their car and drive away. I mean, I've seen cases of where that's happened. Oh, well, just drive home and let me know if you're having a problem. And they had an automobile accident, which made everything for everybody much worse. You don't want to take a casual approach about seeing their PCP or another provider like you might want to, and failing to document what went on. Next slide, please. Tomorrow morning, there's no need to be fearful of delivering a competent cervical spine adjustment. Number 2, pay close attention to the patient's presentation and his or her response following cervical spine adjustments, and do not assume it couldn't happen in your clinic. Next slide. Authorize your staff to dial 911 if they feel that the patient needs emergency care. Document, 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 and understand the mechanisms involved and respond accordingly. Next slide. Evaluate your procedures in general. Are you asking the questions you should be asking? Are you and your staff attuned to catching subtle changes in your patients? And, you know, does your staff have mechanisms or authority to let you know about things they see in patients? Number 8, act in the best interest of the patient. Always and always. And this is in your best interest also. Next slide. Here's the important my final advice. Based on current scientific literature, it is this presenter's professional opinion that a properly administered chiropractic adjustment cannot harm a healthy vertebral artery. However, if a dissection is in progress, a cervical adjustment can make things much worse very quickly. Next slide. Also based on current literature, it is this presenter's professional opinion that most strokes in chiropractic clinics were in progress when the patient presented for treatment, and why it's absolutely essential that the doctor and staff be able to recognize those signs and symptoms. Next slide. Also based on current scientific literature, it's this presenter's professional opinion that strokes do not occur in chiropractic office in any greater frequency than they occur in the offices of medical physicians. Since MDs do not perform manipulation, in my opinion, it is highly unlikely that cervical adjustments cause strokes. Next slide. I want to reemphasize, as Shannon did earlier, this presentation is a condensed, revised, and updated version of Dr. Jerry Clum's video presentation endorsed by the Association of Chiropractic Colleges. This webinar, along with Dr. Clum's full video, will be placed on the help desk to hopefully ensure that the current and future doctors have the tools to recognize a vertebral artery dissection in progress and to take the necessary steps on behalf of your patient. Next slide. I've put my contact information up here. The last thing is probably the best way. The last one is the best way to contact me, which is by email at james.edwards@thejoint.com. james.edwards@thejoint.com. If you have any questions or need additional information, please email me and I will respond. I truly appreciate the attendance on this. It is important, and it is important to know these things, because everything can be avoidable if you know what's going on and know what to do. That's it for me, Shannon.
All right. Thank you very much, Dr. Edwards, for the presentation today. Everyone, as Dr. Edwards mentioned, if you have any questions for him, please reach out via email. We are not going to open questions up at this time. And that concludes the presentation for this morning. Thank you all very much for attending, and have a great day. Thanks.